I'm going to analyze another scene from the Pitt dealing with an infectious disease problem that sometimes occurs when you're taking care of patients.
Aquinas syndrome,
You writing the great American novel?
charting and supervising. It's Dana's idea.
Who is the lucky patient?
Unhoused woman with a bad cough. Ogilvy's all over it.
So you're hearing about an unhoused woman with a bad cough. That could be really, really long in terms of the differential diagnosis of what it could be. It could be garden variety things like COVID or influenza. It could be lung cancer. It could just be bronchitis. It could be a reaction to certain medications. But the fact that they're saying unhoused is trying to trigger something, meaning that that person likely is exposed to people in homeless shelters or other types of settings. And that might narrow or at least want you to include something that might be common in that population or that might be associated with it as a risk factor. So we'll see what comes next.
Okay, deep breath in, blow it out real hard.
You haven't heard enough already?
I need to check for wheezing with forced exhalation.
Fucking cough is killing me.
You smoke, Mrs. Yardley?
Yeah, but I haven't been able to for a couple of days because of this cough.
You ever consider quitting?
So you're seeing the medical student now listen to her lungs with a stethoscope. That's called auscultation. And he's listening to see, is she making wheezing sounds? Are there other sounds that you're hearing? Are there crackles? Are there gurgling sounds? That's basically what he's doing. And when he's doing that and she's breathing pretty deliberately there, she coughs. And now when you cough, particles come out of your mouth that are now going to be in the air. They're going to travel for some amount of feet, and some of them are going to stay suspended in the air. And he's in there, and just note he's not wearing any kind of personal protective equipment, no type of mask or anything like that.
You ever considered minding your own business?
Well, the good news is that your test from earlier came back negative for both COVID and influenza, but I'm going to order a chest x-ray so that we can see what's really going on in those lungs. You got time to let us do that?
So the medical student is telling the patient that he's tested her for COVID and influenza, common things, and those are negative, and now he's going to get a chest x-ray. Chest x-ray is going to give you a picture of her lungs to say, do the lung fields look normal? Are there areas that are whited out from pneumonia? Are there areas where there might be cavities or holes in the lungs? Is there any mass there? She's a smoker. Could she have lung cancer? All of that's going to be delineated with a chest x-ray.
Where the else you think I gotta be?
Of Aquinas syndrome, but the motor and sensory exam were both intact in the
Our unhoused cougher has pneumonia.
I'm cursed. Cursed.
What?
Now he's taken the iPad, which has an image of the chest x-ray on it, and showed it to his senior resident, Dr. Santos. And he's saying that she's got pneumonia, which means he likely sees an area on the x-ray that is white that should be black, where there should be air, but there's pus, inflammatory markers. And she continues to cough in the background.
That is a cavitary lesion in the right upper lobe. Active TB. What's next?
And there's the money shot. You see a picture of that chest x-ray. You see in the upper lobe, the right lobe, there is a cavity, basically a circular region, which is basically exactly what a cavity would sound like. It's kind of a hole in the lung tissue. And because of this cough, because she is unhoused, this leads Dr. Santos to correctly conclude that you have to think about tuberculosis. And she uses the adjective active. Active tuberculosis means that that the tuberculosis infection is not dormant, it's not latent, it's actually producing new bacteria, producing new inflammation, producing symptoms. And what's really important about active TB is that it is contagious. And she's been in a normal room. People have been in and out of there without personal protective equipment. And that's the next thing that we're going to hear about.
What's next?
AFB stain to confirm, move her to a negative airflow room, start her on meds.
Call infection control and public health. And now you get to sign in as a patient and get your blood drawn for a quantiferin gold.
The medical student Ogilvy says, what's going to happen next? test her sputum for AFB. So what does AFB stand for? Acid-fast bacillus. That means have her cough up a sample of her sputum and then stain it with a special stain and put it under a microscope. And basically you're looking for bacteria that pick up that stain and look very characteristic of tuberculosis. So you're trying to see, are there active tubercular bacilli in her sputum? That's what an acid-fast stain will show. And someone who is sputum positive or smear positive is how we would say it, that her sputum smear is positive for acid-fast bacilli, that person is very contagious. Dr. Santos is saying call infection control. That those are the people in the hospital that keep track of people who need to be in isolation. He's just said put her in a negative pressure room. What's a negative pressure room? When you're in a normal room, the airflow kind of just goes as it goes between the inside of the room and the outside of the room. A negative pressure room keeps the pressure as such that air flows into the room, but does not flow out of the room. So it's at negative pressure to the outside. So the air will flow in, but air doesn't flow out. That delimits any kind of spread out of the room. So they need to move her to that. She's said to call public health. Public health will have a role here in trying to figure out where she might have gotten tuberculosis and who in the community she might have been exposed to. You've heard that she's unhoused. Maybe she was in a homeless shelter. Maybe she was at a soup kitchen. Maybe she was staying on someone's couch. All of those are going to be important for public health to find and understand, and then do testing to see, were these people exposed to tuberculosis and do they need to be treated? She's also said now that the medical student is a patient. Why is he a patient? Because he was just exposed to active tuberculosis without any personal protective equipment.
For a quantiferin gold.
It's too soon to be positive.
Yeah, but you were exposed. You need a baseline test and then again in 8 weeks to see if you convert.
She has now said that he needs a test called quantiferin gold. What is that? That's a blood test. So they take some vials of blood and they're basically looking for a type of your white blood cell, a lymphocyte, a T lymphocyte. And they take it out, they take that T lymphocyte and expose it to proteins of tuberculosis and see, does that T lymphocyte get active? If it gets active, that tells you that the person has seen tuberculosis. Their immune system has seen tuberculosis. It's not a diagnosis of active tuberculosis, but latent tuberculosis, because tuberculosis, when you get exposed, doesn't automatically go to active disease. It starts out, a small percentage can go active. Most of them go into latent tuberculosis, and then later on in their life, maybe they get immunocompromised, they reactivate. She's saying he needs a baseline. The baseline is going to say, has he been exposed to tuberculosis in the past? So you need to say, what is his baseline? And then repeat it 8 weeks later, or some duration of time later, to say, did it convert? Did it now go from negative to positive? And was this exposure relevant to it? We used to do skin testing for this, but quantiferin is a lot easier to interpret. It's a lot more objective, I would say, because it's not relying on somebody measuring something. It's actually a laboratory test. So that's what's up. That's what he's up for next.
You need a baseline test and then again in 8 weeks to see if you convert.
And if I do?
Then meds every day for 3 or 4 months with regular blood tests to check for toxicity.
Jesus.
So she's saying if he tests positive, meaning he developed latent tuberculosis from this exposure, he's going to need to put on prophylactic medication so that it doesn't reactivate, to decrease the chances of that latent tuberculosis becoming active. And there are different regimens, and they've become simpler and easier to take. They used to be 9 months of a drug. Now it can be shortened to a couple of months using different drugs. So drugs like isoniazid, drugs like rifampin, there's multiple different regimens that you can use. But the thing about these drugs, these antibiotics, is that they have toxicities. Some can cause liver disease is the primary one. So you have to get your blood work checked to make sure that it's not causing liver toxicity.
All right, let Dana know what's up, and for the love of God, mask up when you move her. The patient's symptoms are consistent.
So she's telling him to mask up when he moves her. So use personal protective equipment, and you see somebody there donning an N95 mask, which would be the type of mask you would use when you're trying to prevent infection with a pathogen like tuberculosis.
With lumbar radiculopathy at L4, L5, most likely due to disc herniation.
Coughing patient admitted to isolation for verified medication administration and started on right therapy.
Yeah, why do I even bother? Just fail me now. Okay.
So now Ogilvy has come back and said the patient's been admitted to isolation for RIPE therapy. What is RIPE therapy? Those are the drugs. So when you treat active tuberculosis, you start with 4 drugs up front until you get sensitivities back of the bacteria. So rifampin, isoniazid is the I, pyrazinamide is the P, E is ethambutol. And you give those drugs for all 4 for a couple of months until you start to get sensitivities back, and then you can start peeling away some of those antibiotics. And he says visually observed therapy. So that's something we often call directly observed therapy. So individuals where you're not sure if they're going to be able to take the medications, you watch them take the medications, because if they start missing doses, not only will their tuberculosis get worse, it might become resistant. And remember, this is a contagious person, so they could be spreading drug-resistant tuberculosis.
Now, okay. Get in touch with a social worker. They're going to want to do contact tracing and help her figure out transitional housing for when she's discharged.
Got it.
And make sure infection control responded. The people in the waiting room could have been exposed. They need to be notified and tested.
So she's talking about having social work, helping her find transitional housing when she's discharged, because you don't want her out on the streets with active tuberculosis, or even with tuberculosis that's not active anymore, because she needs to take these medications. They need to figure all of that out. Infection control needs to know about this, not just for her isolation in the hospital, but because she might have exposed people in the hospital, like medical student Ogilvy, but also the people in the waiting room that were sitting next to her.
Okay.
Relax. You can take the mask off. You don't have TB. At least not yet.
Oh, great. This is up. How are you so calm?
Expected job hazard. You get used to it.
Yeah, no thanks.
70% of doctors in training at urban hospitals get exposed to TB and wind up on meds.
Jesus. They don't teach you that in med school.
So you're hearing about the fact that in urban hospitals, many training doctors get exposed to tuberculosis and end up taking medications. Yeah, that's true. I don't know if the 70% number is exactly true, but it is definitely a significant percentage, because you are taking care of patients and they might be presenting with symptoms that look like an ordinary cough or cold, but then you find out after the fact had tuberculosis. So this is one of the reasons why you have to be vigilant, where you have to think, does this person have risk factors for tuberculosis? What are some of those risk factors? Being unhoused, being immunocompromised, being exposed to tuberculosis, being from certain countries that have higher prevalence of tuberculosis, being incarcerated. There are many different risk factors that you have to always keep in your mind when you're taking care of someone with respiratory symptoms to make sure, is this tuberculosis or could this be tuberculosis? And when in doubt, err on the side of caution, meaning put the patient in negative pressure isolation. Tell them to put tuberculosis isolation placards on the room, because you can always take them out. But if you get people exposed, and remember, there might be immunocompromised people sitting in the waiting room or in the next room over, that can become very challenging and daunting for a hospital to control. So err on the side of caution if you think a person might have tuberculosis, and put them in isolation and then take them out when you find another diagnosis. Remember, tuberculosis is the #1 killer from an infectious disease standpoint of humans. So this is something that is not uncommon, even in the United States, where there are approximately 10,000 cases of tuberculosis diagnosed each year.